Yes, thank you very much, and thanks to Ian who asked me to give this talk. And thinking about it, I wasn't quite sure exactly what to do, so it's a sort of a bit of a round trip around some general principles, a study which is essentially an unusual study which is thrown in there, and then also the final bit about the potential for the future, and particularly the use of linked data, which ties into previous presentation. So I thought I would very quickly just zip along with some scale issues of the injury burden, talk a little bit about where to get access for the evidence base for preventive interventions, a bit about the whole multidisciplinary and interagency basis of injury prevention, which is somewhat different to most things in medicine. One study which attempted to increase the uptake of known effective interventions, and then finally the bit about the opportunities for prevention research using large-scale record linkage. So just to show you some figures, these are from an unpublished study I ran for a number of years, I think, called the UK Burden of Injury Study, which was a prospective longitudinal study at 4 centres in the UK of about over 1,500 injured individuals, and then linked to lots of different databases. And it sort of shows the sort of numbers. These are all ages of people who are hospitalised with injuries in the UK in a year, or who attend emergency departments, and deaths, and some costings just for direct medical care in emergency departments and inpatients. And then also there is built into this a system of using a thing called disability adjusted life years, which is used by the World Bank and World Health Organization and other bodies to, essentially, if you like, rank the importance of conditions, and depending on how that is, the societal cost of injuries in a year in the UK would be some £53 billion. But the treatment costs are about £3 billion, which is not inconsiderable, and since everybody knows the current government are about to cut £6 billion in a year, and we'll get to feel what that's like, get a sort of sense for it. And this essentially here, these disability adjusted life years are basically have two components. One is how they measure premature mortality. They call that years of life lost. And then the other one is for the people who live with a disability and years lived with disability. And this is actually a counter audit and a rate from part of that study, looking at this, if you like, the age groups which contribute most to the premature mortality. And you can see there essentially teenagers and young adults particularly falls off, obviously, as people get older, and considerably higher in males than in females. And if you look at the disability component in survivors, you get a slightly different picture, but again, essentially, teenage children would have the highest amount, or the highest numbers that would add to the UK burden. A little bit on the evidence base for effective interventions. Like everything else, the literature is enormous and growing. There are huge numbers of papers, and people who are interested in injury, there is essentially a safety net thing that goes around with hundreds of publications each week, which is updated by the University of San Diego. In the Collaboration for Accident Prevention and Injury Control in Wales, which I run, essentially keeps an updated list of all systematic reviews to deal with any aspect of injury prevention, whether it's intentional, unintentional, in all ages, which is on the CAPIC website, and also it links to a thing called the Injury Observatory for Britain and Ireland. And you can find all of those, anyone who's interested in prevention, that information there. So it's a free, updated, searchable database of systematic reviews. There's also, the Injury Observatory produces a thing called Injury Prevention News, which is a sort of entire electronic publication free to anybody who cares to send their email, and that goes around to many thousands of people in different organisations, about 3 or 4 times a year. But actually, if you look in depth at the evidence base, there is limited high quality, really good quality evidence on the effectiveness of prevention and targeting. A lot of what's done is based on logic and our knowledge of the laws of physics, and if something causes an injury, then you think, well, reversing that will immediately undo that. But if you look at it in depth, that not all good ideas or ideas which are seen to be good are actually later shown to work, and there's some good examples of things people thought would work but actually worked in the opposite direction. And obviously the Cochrane systematic reviews are the highest quality of the scientific evidence. There are a considerable number on injury prevention. I just put one up here for an example, and this is one about actually how to get smoke alarms into homes to prevent obviously house fire and burns related injuries, which was sort of put together by Caroline Di Giuseppe. And essentially they had 17 trials. What they showed is that just advising and counselling people had modest but important increases in uptake. Very few of these actually evaluated the effect on things like the number of fires, very few on the number of injuries, and those that did have inconsistent results. And the biggest effect was essentially a free installation program in Oklahoma City, which basically they put fire alarms in just one half of the city and not the other, and watch what happened. But there are lots of potential biases as to how that worked. So what we often can see from the evidence base is that there are a number of interventions which increase uptake or change behaviour, but it's very rare that we can see measurable effects on injury rates. But the problems we have is that the studies are generally too small to answer the, if you like, the injury question. Very often the changes are modest, and so you come to the bottom of this, which is very difficult to actually fund studies which are sufficiently big and long-term in an experiment to show an impact on injury rates. And that's a real challenge. Lots of different approaches to injury prevention. The ones that tend to be least effective are the unidisciplinary, just a single discipline involved. The combination of people from different backgrounds and disciplines generally more effective. There's a thing you will see in the literature all the time about in injury prevention, the 3 E's, essentially, which relate to things like engineering approaches to prevention, enforcement, which is important in some areas in education. The evidence base for education alone, as I said, is limited, but also when you look at these studies, the contextual issues about how things were tried in different places, to what extent they worked or not, very important. And another area, of course, which is as important, is the things that we know to work, is actually the sort of the evidence base. Getting that sort of research into practice is as important as new research. So I thought, rather than go into things in great detail, I'll just show you an example of a very unusual study which we led. I'm amazed was funded, the Advocacy in Action study. And just a background to this, this is about attempting to get evidence-based interventions in to reduce child pedestrian injuries in deprived areas with high injury rates. So there are big health inequalities. The biggest of all health inequalities occur for child injury deaths, right? They are much bigger than any other health inequality that exists. Pedestrian injuries show very substantial inequalities. If you look internationally, the UK does quite well on road injury deaths, but very poorly on child pedestrian injury deaths, and far too many children are injured or killed on our roads compared to how we do on other aspects of safety. There are a variety of effective interventions which are available, and most of these are not implemented for a variety of reasons. And a piece of work that we previously did and published showed that getting things like traffic calming and interventions in place was influenced by politicians, councillors who are influential. And what we did was we developed a cluster randomized intervention trial to effectively interfere with the political process to try to get local politicians to support improving pedestrian safety in deprived areas where there was a high rate of injuries. And it was funded by the Department of Health, which is quite amazing because it was a real interference in the political process, but it was largely in the transport sector, so they probably felt that wasn't so much their business. And what we did was identifying deprived areas which have high pedestrian injury rates and the politicians which represented those areas. There was an information and an advocacy pack developed to try to actually influence the ones in the intervention group, supported by the Child Accident Prevention Trust. And then we undertook this cluster randomised trial. Now, essentially it had 4 centres between different universities. I'll show you people involved at the end, in South Wales, in Bristol, Nottingham and in Surrey. And it involved over 600 politicians who were entered into the study without consent. Because they represented areas, they were in it, there was nothing they could do about it really, from about nearly 60 district councils. It involves a lot of large-scale geographic information system analysis on the location of road traffic crashes and where traffic calming features have been put in, and essentially off it went really. That's essentially something, this is like a small area map, which you probably don't see quite so well here, but it's an electoral ward. It is an area that a councillor represents, and there are many, many thousands of these across the country. And basically it shows the boundaries of it, and it shows the roads in it, and every black dot is location where a child or a person over 60 was injured, being knocked down by a car over the previous 3 years. We had to get special permission from the Department of Transport to show the politicians what was happening in their areas, and that was an interesting negotiation because this sort of information is not in the public domain. And part of the follow-up data, which you probably see a bit better, it's the same wards, uses the sort of red areas, which are actually traffic cam segments, which come from analysis of large-scale ordnance survey data. Now, very quickly, what we did, this ran for about 3 years, we were able to significantly increase some of the short-term outcomes in increasing interest in the politicians, the belief that they could take action to do things, the knowledge of the interventions which essentially worked to help with pedestrians, but it didn't change significantly any of the safety on the ground over about 3 years. So overall, I say disappointing results. We didn't improve the safety on the ground. There was quite positive findings on their intent and engagement. Lots of barriers identified. There are very many people involved in decision making and prioritisation within councils. There are long timescales when you're attempting to implement change, and you do get some officials who are resistant to what they saw was our interference in the political system. It worked best, I think, where some of the information leaked into the public domain and was on the television and newspapers. So our proposal at the moment, which we have had support from the 4 chief medical officers, is actually to put the whole lot in the public domain and allow people access. We're still trying to negotiate with bodies to actually, people could look at how safe or dangerous their area was, how much was being done to fix that, and if they felt they were shortchanged, that would give them ammunition to make a difference. So that's where we are with that one, and that's the sort of people who are involved from essentially Swansea, Nottingham, University West of England, and Surrey, Child Accident Prevention Trust in London and that. And sort of finally I sort of finish with a bit about the use of linked health and non-health data to support research and policy development in this area. I'm one of the 2 co-directors of the Health Information Research Unit, which is funded by the Wales Office of Research and Development. It's part of the strategic infrastructure for research in the UK and Wales, I used to sit on a thing called the Office of Strategic Coordination for Health Research, OSCR, which sits above all the research councils and government departments in the UK, and that had a board called the Electronic Health Records Research Board. And similar systems to what we have here in Wales are being developed in Scotland and in England, but they are quite a bit behind, really. Our thing was facilitated by a sort of large-scale computing and support from IBM as part of a £50 million development in Swansea. And one of the things that we've created is this thing called SAIL, the Secure Anonymised Information Linkage System. The one in Scotland is called SHIP, Scottish Health Information Platform, but sadly the people in England had no imagination whatsoever, and it will be called the Health Research Support Service, and they should have thought about something a bit nautical. Anyway, what do we do? Well, essentially we have a system for linking and anonymising data at individual and household level, and that's been done across multiple data sets. And the information is taken from health services, some from social care, some from education, housing, and increasingly, with our areas of injury prevention, fire and rescue service data. I won't go into the complexities how to do all of this while staying legal and within all data protection regulations. Just to say that we use a whole pile combination of splitting files into bits about the file which actually have identities on them, no content, and vice versa, and using several different organisations to do pieces of work. That all results in protection of confidentiality, and there's a lot of encryption and other things then. It ends up with the NHS linkage body, effectively, who does all the linkage, knows nothing about the data content. And the people that I work with essentially know nothing about the person's identity. But we can actually anonymise the entire population at an individual and household level whilst doing this. So this is a demonstration slide of a year in the life of a person within some of our data sets. And essentially there are 5 data sets: emergency department, attendances, inpatients, outpatients, GPs, and this is a social services data set. And this exemplar, actually, it's an older woman who had falls, and each time she was admitted to hospital, lengths of stay, there were trauma, outpatient attendances, and some general medicine, and lots of the GP stuff. And this here actually was the installation of a lifeline pendant for falling. And before all of this, nobody would ever see that sort of pattern or understand how all these things are related. So it just shows us this interesting picture, but it's not something that we use when we're involved in analysis, because we do very large-scale data analysis. Being able to essentially track anonymised individuals over time, and actually within household groupings, is very valuable for research. We actually never know who the people are, where they live, but we can do a lot of interesting things. The effects of housing improvement on health, how the physical environment impacts on health, and some of these sort of interagency collaborative research is all supported by this. So this is just an example of some work we've started to do with the fire and rescue services in Wales. And actually it's to help them to develop new models of fire risk, because they do a lot of interventions to reduce fire. And we use the system with their data, actually see if we can develop new risk models by housing category and resident profile. And then that will then be used in the second part, which is that they were willing to change how they approach engaging with people on their home fire safety checks, and to see how that will work. So I'm going to sort of finish now and get back on time quite nicely, just to sort of go over this, that obviously injury is a major public health issue with substantial numbers and costs to the NHS, never mind the cost to individuals. If you look at how important injury is compared in terms of DALYs or any other metric, and then you look at how much money is invested in prevention and research, it is one of the Cinderellas in which very little research money is invested. The CAPIC and the IOBI websites, for anybody interested in just finding systematic reviews that have anything to do with prevention, is freely available. Anybody who wants to sign up for the Intervention News can do so through those websites. And essentially this multidisciplinary and interagency collaboration supported by record linkage, we think holds the key for a lot of larger scale, more affordable research. And I want to say that we also use it for very many other types of health research not related to prevention or injury. There are very many studies which are now embedded in this going on. So that's me done. Up time. Yeah.
It's fascinating. Could you use this for service evaluation? I'm particularly thinking of the reviews of children's cardiac services. There's a review going through at the moment of neurosurgical services for children. Would you be able to use this kind of information to say, well, in these areas it would appear that they're not getting, say, their surgical evacuation of hemotome in 4 hours?
You could. I mean, when we set up our system, we deliberately excluded performance management to encourage people to put information in for research. Under the philosophy, essentially, that was information, is for learning, not blaming. And that actually encouraged a very large number of organisations to put the data in because they knew what we would not be doing is a lot of league tabling. Now, I know that lots of people want to do league tabling, and there are, I think, separate and different systems for that. And, I mean, mostly when I'm asked, I tell the people, well, what they should be doing is, they should be members of TARN, ICNARC, PICANET, the renal registry, keep on going, because those specialist bodies are the ones which have essentially professional support and are best equipped to do that. Particularly GPs and social services were very reluctant to put any data in if we were going to be doing more league tabling, so we don't. We can, however, do analysis which actually show general patterns rather than doing that part. And we have been using the system in collaboration with people in Australia and TARN, looking at head injury survival in Victoria, Australia, and in the UK, which has very interesting findings, which will be submitted soon. That's all ages, so this is not children. But the answer was just get on the Qantas plane. I'm afraid to say. Bit different.
Very interesting, yes. It's an area I didn't do that actually. So, thank you very much again for presenting that. And